and this session is going to start its recording now. And this session is going to be available for download on your mobile phone after the session finishes. Okay, so we have a Telegram group. If you want to download this session and carry home these pearls of wisdom, it's going to be available to everyone. I'm not going to broadcast this session on the Facebook group. I'm going to post the link of this session on the Facebook group for anyone who wants to download it. Okay. This session, let me just tell you that this entire session is going to revolve only around IUI. Okay, and as we all know, we are expecting a few more people to join in, but then I think it's okay. Let them listen to the introductions as a part of the recorded session. See, IUI is something which we all do, or we all want to do, all right, or we all have been doing very successfully. And the very fact that we have Sachin Bhai with us is because he's one of those guys who is able to, tweak the protocols for anything. It could be a protocol for IVF, it could be a protocol for natural cycle transfer, it could be something related to triggers, it could be something related to low AMH, and he's very well known out here in the city of Bombay and Maharashtra for tweaking these protocols, to optimize the success rate for this entire procedure in your own laboratory. And for all those of you who don't, first of all, I don't think there will be people who haven't heard of him. But then for all of you who don't know him, he's the director of Madhu Group of Hospitals. Let me call it a group of hospitals now. And he's a very well established gynecologist and an IVF specialist out here in Bombay. And he is one of the founder members of this Project Pelvis. Okay, it was actually my and Sachin and Vikram and 3-4 other people. We thought that, we will have a platform like this where we can show live surgeries on Facebook and have such interactive sessions and all these things. So all the success which goes with Project Pelvis, a lot of it comes, through his guidance. So he's going to be our speaker and he's going to be speaking on IUI. 2 moderators. One is Dr. Venugopal from Kerala, from Thrissur. And for all the people who just joined in, Dr. Venugopal is my teacher from Kerala, and he himself is the director of ARMC Thrissur, and that's a very well-known IVF chain of clinics out there in Kerala. And Dr. Venu himself happens to be very, very well acclaimed as far as using assisted reproduction and all the other procedures in our field is concerned. So thank you, Venu sir, for taking out time and joining us today. And then of course we have Dr. Rajesh Koradia. So he's one of those guys who I'll give you a different type of an analogy. He's one of those guys who donates a few crore rupees to the PM Cares Fund, okay, and he never makes a hype about it. And I really think it is guys like Dr. Rajesh Koradia who let me be honest with people. I have had the opportunity to go and work with him. Okay, I've gone to his hospital. I've worked with him. I've seen him work in his IVF laboratory. If at all anyone ever wants to set up a good fertility practice, okay, you can idealize this guy. All right, he's thorough in knowledge, thorough in practicality, absolutely down to earth, and he's pretty blunt. He's not going to tell you things to make you happy. He's going to tell you things to make your practice good. And if anybody wants any form of honest opinions on this planet, then I think you can consider Dr. Rajesh Koradia to be on your speed dial list. Okay. And I think over the last 1 year at least, ever since the concept of this verdict group, this is a group which is run on Kaizala. And when you see him teaching or over the last 1 year, I think I would have, since that lockdown, I have not missed a single session which has been taken by Dr. Koradia. And let me tell you, after those sessions, okay, this is a blunt figure. Most of you know my numbers, Koradia sir and Sachin Bhai and all these people know what IVF work we do. After his guidance and after using some of his protocols, some of his techniques, I'm very happy to tell that it has increased my clinical pregnancy rate in the range of close to 27 to 30%, which was initially around 22, 23, 24%. And I think a lot of credit of those 5% goes to Dr. Koradia. And simultaneously, he was the guy who was very inspirational in me installing the time lapse in my hospital. So Rajesh sir, really, I mean, I can speak more on this, but Thank you so much for all these selfless things which you've done to us. Thank you. Really, thank you so much. Okay.
Thank
So
you.
through this entire session, initially Dr. Sachin is going to have a presentation which is going to go on for around 35 to 40 minutes. And after that, the flow of events will be such that Dr. Koradia and Dr. Venu will be asking questions to Dr. Sachin, and these questions could probably go on for another 30 minutes. Now remember, when you have Dr. Koradia and Dr. Venu, in fact, audience will not have to ask questions, okay? Because they will pick up such questions and ask Dr. Dalal that usually the answers which come out will be very good take-home messages, okay? So we have a few people who have joined in from international community. I think I can see a few people from Egypt. I see 2 people from Saudi Arabia. So welcome all of you. And Dr. Sachin, I'm handing everything over to you now. You can maybe speak for a minute and then you can start your session. I have enabled screen sharing for you. Okay.
Okay. Thanks, Jay. Thanks for that elaborate introduction. It's been my honor and privilege to be a part of Project Pelvis and also admin of the Verdict group, where we have only strived to selflessly teach newcomers and old people foraying into IUI and IVF and better their success rates in the field of fertility. So without wasting much time, I would like to start my presentation.
Yeah. I think we can see your screen. We can see your screen.
Yeah, right? Okay. Am I loud and clear?
Yes.
You're loud and clear.
Okay, fine. So I'll start off. So good evening, respected seniors and my dear colleagues. The topic for today is IUI the Sachin Dalal way, but let me assure you there is no Sachin Dalal way. I actually wanted to have this topic IUI revisited and reviewed. So what is IUI? As we all know, IUI is an easy basic fertility treatment involving the deposition of the processed semen in the uterine cavity at the time of ovulation. It is globally used, underused by us fertility people, overused by non-fertility gynecologists, and abused by some. So how that happens and what happens will go ahead in the session as it flows. Why are we even talking about IUI when we are having a lot of patients who are coming to us with complications? The basis for my presentation today is this BMJ open paper from Dr. Ghulam Bahadur, where they have analyzed 320,000 IVF cycles and 31,000 IUI cycles. And they found that the IUI success is much closer to IVF at 2.35:1. Thereby, IUI is more cost effective in delivering one live birth, lower risk of complications and maternal and neonatal complications. So they are suggesting to offer IUI before IVF nationally in the UK. In the current pandemic scenario, where a lot of our patients have lost their jobs, lost their businesses, and they are in financial doldrums, we need to offer them a cost-effective treatment, thereby giving them a better chance of pregnancy if they cannot afford IVF. All the papers that I've been talking about today is on the Western Caucasian data. So this is the basis that we need to keep in mind. This is the paper by Dr. Manish Banker and Fertility Sterility, where they combined the ovarian aging between Caucasian women, Spanish women, and Indian women. And they found that antral follicle count in Indian women was similar to Spanish women who were 6 years older than them. So looking at that data, keeping that in mind, we are evaluating the pregnancy outcomes following IUI in women less than 35 years of age with decreased versus normal ovarian reserve. Group 1, AMH less than 1. Group 2, 2,700 patients, AMH more than 1. They concluded that young patients with DOR conceived as often and had per cycle and cumulative pregnancy outcomes similar to those of age-matched controls after IUI. Thereby, they are saying that not all low AMH patients need to be pushed or shifted for IVF. You can try attempting a few cycles of IUI, and if they don't conceive, then go for IVF. And another paper which compared results of IVF versus IUI in women with low AMH levels There's a very recent article from March 2021. They found that pregnancy rates in IVF were 13% and IUI almost the same or slightly more. And they say that diminished ovarian reserve is not an indication for IVF or IUI. Initially, when I started practice, I used to have a lot of girls who used to come with PCOS. Now it's completely opposite. We find a lot of women who come with diminished ovarian reserves, AMH less than 2, and we are at a loss as to what treatment we need to give them. Looking at indications, anovulation remains the primary indication, that is PCOS, unexplained infertility, endometriosis stage 1 and 2, cervical factor, allergy to seminal plasma, and this is not strictly IUI, but women with vaginismus, there have been anecdotal reports of deposition of unprocessed sample with a syringe in the vagina, and people have got pregnancies with that. So if someone doesn't know, this can be tried. Looking at indications for the male partner, all the oligospermia, oligoasthenospermia complex, retrograde ejaculation, ejaculation failure, it can be anatomical hypospadias, micropenis, or neurological, spinal cord injuries, psychological, EDPE that we see so common, and absentee husband, especially in these times when husbands are stuck up abroad or in the armed forces, varicocele, men with varicocele, seropositive partner or discordant couple where the male might be positive and the wife is negative for HIV, and men with raised DNA fragmentation index, DFI more than 10. So the basis for the IUI treatment would be the interplay of the male and female reproductive functions, where couples from group 1 have optimal reproductive functions, group 2 where one partner is suboptimal, other is optimal, group 3 where treatment will be concentrated only on one partner. IUI, we should be looking at couples belonging to group 1, 2 and 3. There might be some indications for using a donor insemination or doing a donor IUI. Which are those conditions? Azoospermia, severe oligoasthenospermia, and not affording IVF as the current scenario is. Hereditary disease in the male and not affording or not wanting PGTA for whatever reason. Repeat IUI or IVF failure with husband sperms. Husband sperms with high DFI, despite doing all sorts of treatment, DFI not coming down. Single women and same-sex couples. Looking at contraindications to IUI, absolute and relative. Absolute is any tubal pathologically, bilaterally blocked tubes, hydrosalpinx, parasalpinx, genital tract infections, PID tuberculosis, stage 3 and stage 4 endometriosis. Relative would be genetic abnormality in the husband, women more than 38 years of age, women with AMH less than 1, more than 4 to 6 IUIs already done, a uterine pathology where there are septate uterus, polyps and fibroids. Now, looking at DNA fragmentation, this is something which is not really done as frequently as it should be. But when we have a couple who've been trying for conception since a long time, where the male is elderly, is having comorbidities, he's been a smoker in the past, we should be doing a DFI in this men. And this study, they found that, sorry, men with Semen baseline DFI more than 10 could be advised against time intercourse and non-stimulated IUI. They found that the pregnancy rates and live birth rates were better if the baseline DFI was less than 10 before starting the IUI treatment. Now, a lot of times we do a sonography during the follicular studies and we find small polyps. So this is the paper from Christophe Blockel's group from Belgium, where they evaluated 6,600 patients, 15,000 cycles. The unadjusted cumulative live birth rate, they found that in women with and without the polyp, the pregnancy rates were 24 and 33%. However, after doing various analysis, ultrasound diagnosis of polyp during follicular phase of the IUI cycle does not seem to compromise clinical outcome when previous baseline examinations have been normal. So how does this impact our clinical practice? If you have a patient who's coming to you as a primary infertility, not done much treatment, and we are doing an IUI and we find a small polyp, for a couple of cycles, we can just ignore the polyp and start with the treatment. And if the 2-3 cycles are done and the polyp persists or grows in size and she does not conceive, it's better to just do a daycare surgery and get the polyp out. Now, going to the hows of doing an IUI, the first and the most important would be a gold standard Sulphingography, which we do in our clinical practice, which gives us a good evaluation of the uterine cavity, the fallopian tubes, and the spill of the dye from the tubes. And if somebody has access to a newer generation sonography machines, they can do a sonosalpingography, and there's a nice 3D reconstruction of the fallopian tubes and the dye coming out from the tubes, which can be done in a small amount of time. So reviewing the steps for IUI, we all know minimal stimulation of ovaries, follicular studies with or without Doppler studies. Trigger is given. IUI is done 36 to 42 hours after trigger. Luteal phase support and a urine pregnancy test or a beta HCG after 14 to 15 days. The premise of ovulation induction in IUI. When we have women with an ovulation, the problem with them is they are not developing a follicle. That is the reason why they are not conceiving. So the idea is that we need to do a monofollicular development. While in ovulatory women, the idea is to do a COH with gonadotropins and have a multiple follicular development. In women with previous IUI who have undergone previous IUI, either with natural cycles or oral ovulations, the premise is that gonadotropins gives a higher E2 levels, which might increase the chances of pregnancy with a nice thicker endometrium that is seen in women who've been given gonadotropins. So I've been asked multiple times that what is my choice of drug? Should I use clomiphene or should I use letrozole when we are doing IUI? So this paper gives an answer to that compared with clomiphene citrate, letrozole is an effective treatment in the IUI cycle, has a likelihood to improve dominant follicles and most importantly, reduce the miscarriage rate. So for primary line of treatment, if the patient comes to us, she's young with good AMH, we can do a couple of cycles with letrozole. And this is the study that mentions that in women who had undergone gonadotropins or clomiphene citrate, the clinical pregnancy rate was 31% in the gonadotropin group and 26% in the clomiphene citrate group. And they concluded that gonadotropins are more expensive, as we all know, and without being significantly more effective, we can start IUI with a clomiphene citrate. Comparing gonadotropins versus oral ovarian stimulation agents for unexplained infertility. This is a meta-analysis of 6,590 cycles. They found that singleton births per subject were similar between both the groups. And the randomized data do not support the use of gonadotropin for ovarian stimulation in IUI, especially in women with unexplained infertility. The effect of gonadotropins and endometrial thickness on pregnancy outcomes in patients with unexplained infertility or PCOS undergoing IUI. It is always better to have a thicker endometrium in a woman whom we are stimulating, as they found that in women with endometrium less than 5 millimeter, there was 0 pregnancies, 12% in 5 to 6.9 millimeters, 15.5% in 7 to 14 millimeters, which increased to almost 33%. Thereby, increasing the dose of gonadotropin to stimulate more than one follicle to develop may benefit the endometrial proliferation and improve the IUI outcomes. As in IVF, we want at the time of frozen embryo transfer to have a thicker endometrium. Similarly, in IUI, it is always better to have a thicker endometrium than to have a thinner endometrium. So looking at our stimulation protocols in non-PCOS patients, we do a baseline scan on day 2, day 3 of the periods. And I prefer starting with HMG XP or HP 75 to 150 international units daily. The MarQ we use daily. We do not use any alternate day. If the patient is not affording, we can use it in combination with oral ovulogins. People have used oral ovulogins, letrozole for first 5 days, starting from day 2, day 3, and adding HMG on day 7, 8, and 9. Or there have been people who have been using in every alternate days. But the recommendation is to use it daily. I normally require 6 to 8 doses. Maximum requirement has been 10 doses. We do follicular studies and Doppler studies with PSV. PSV stands for perifollicular systolic velocity. Around the time of peak maturity, the PSV should be more than 10. That indicates a maturity of the follicle. We give the trigger. Initially, for a single follicle, we used to use HCG 5000. But with HCG 5000, we find that a lot of times that single follicle also does not rupture. So we've now gone to giving HCG 10,000 for all patients. It might sound like an overkill, but it ensures that we get a follicular rupture. Nowadays, in the past 6 months, we are finding a new a syndrome coming in wherein despite giving HCG 10,000, the follicular rupture is not happening, not only for IUIs, but also for normal planned intercourse patients. In these patients, we are giving them a dual trigger. I'll come to dual trigger later on. Do an IUI after 36 to 42 hours. We prefer doing a single IUI in self cycles, preferably before rupture. The idea is that the sperms are already present in the system to go and attach to the releasing oocyte, and double IUI in patients with oligoasthenospermia and in men with azoospermia, where we are doing a donor IUI, where we prefer doing IUI 2 times. One is 24 hours after trigger and another is 48 hours after trigger. So looking at stimulation in PCOS, there is a slight variation in this, what we like to do. In PCOS, I prefer giving them a combination of metformin plus or minus inositol, depending upon whether they're able to tolerate it or not, whether they're able to afford it or not. As we all know, inositol is an expensive drug. I prefer giving it for 2 to 3 months, thereby decreasing the serum insulin levels and giving a better response to ovarian stimulation. My first protocol, which I've talked a lot of times on the groups, is an extended letrozole protocol, where I start with 2.5 or 5 milligram OD, and it is continued till trigger. I don't stop it at 5 days or 10 days or 15 days. I might stop it once the lead follicle crosses 16 millimeters. It gathers momentum on its own, but I prefer giving it till trigger. It has given us excellent results and good pregnancies. Clomiphene citrate should not be used as per the latest ESHRE ASRM guideline on treatment of PCOS. Low dose taper protocol we've used occasionally with mixed results. The idea is to develop 1 to 2 follicles, maximum is 4, beyond which we prefer cancelling the cycle or conversion to IVF if the patient is willing for that. When we see a multiple follicles growing, sometimes we do think about starting an antagonist, that is to prevent ALH surge. A few of us have been thinking on using antagonist at half dose, 0.125, though it might not sound very scientific, but it has worked, especially when we are using it in IUI and preventing the LH surge and giving us good results. For the uninitiated, the low dose step-up protocol would be starting a dose of 37.5 to 75 international units of REC-FSH. Give it for 7 days, scan after 7 days, see if there is no dominant follicle more than 10 millimeters after 7 days, step up by 37.5 to 50, step up every 7 days till the lead follicle touches 18 millimeters. Or the endometrium and the endometrium should be 7 millimeters. Give the trigger and perform an IUI. There was this nice paper, an Indian paper, which compared the letrozole step-up protocol with letrozole plus gonadotropin. This is an Indian paper and this is evaluating the results versus the cost factor. What they've done is, in one group, they've given letrozole from day 2, day 3, on first day 2.5, second day 5, third day 7.5, and fourth day 10 milligrams. In the second group, it was given letrozole 2.5 milligram BD, that is 5 milligram for 5 days, and HMG 150 was used every alternate days from 7th day and titrated. HCG was given when the lead follicle was 17 mm and IUI was done after 36 hours. They found that the clinical pregnancy rate was 10.7% in group A versus 16.67%. This was not found to be significant, but they could achieve multifollicular development with use of letrozole step-up protocol even without the addition of gonadotropins. So if we have a patient who's not affording for gonadotropins and we want to develop multiple follicles, this is something that can be tried. A comparison of oral versus injectable ovarian stimulation in IUI in women more than 38 years of age with decreased ovarian reserve. This was a nice study which found that in women more than 38 years of age, they got the maximum pregnancies with letrozole, mind you. Next was gonadotropin 7.5, and the least was with 5.3% with clomiphene citrate. Somebody is annotating, Jay. How do we change that?
1 minute. Let me. I think.
Yeah. Okay. I did that. Yeah. Okay. Yeah. Fine. Okay.
I've suspended participant activity, so I think it should stop now.
Fine. Okay. And I'm clear, right?
You are
Yes,
absolutely
yes.
audible. I
Yeah.
just got one message from someone requesting you to be slightly slower.
Okay, I'll do that. Another study again, Jay, just check. I think there is annotation is happening. Just try
I
disabling that.
I actually suspended all participant activities. See this?
Okay, I just did disable annotation for others. Okay, so that works
Yeah.
now. Okay, fine. Okay, so looking at this paper recently published, we have all been taught that mature follicle is a follicle of 18 millimeters. This group, they defined a mature follicle as more than 14 millimeters at trigger. This was something new that I learned. They have evaluated 25,000 women, 50,000 cycles. They found that increasing the number of mature follicles from 1 to 5, mind you, from monofollicular to multifollicular, at the time of IUI in younger women less than 38, increased the clinical pregnancy rate from 15% to 22%, which is a massive jump. In women less than 40 with 3 follicles, found that 25% of the pregnancies was multiples, which in our country, I think a lot of patients would be happy about it. And in women more than 40 years, up to 4 follicles tripled the odds of pregnancy while maintaining less than 12% risk of multiple gestation. So this is the premise on which we would like to give patients gonadotropins for stimulation. Jay, my next slide. Oh, okay, fine. Now, we are often asked, how long should we give the stimulation? So there is this paper which they have studied the effect of follicular phase length on cycle outcomes, endometrial development in gonadotropin IUI cycles. They found that clinical pregnancy rate increased by 6% with each additional follicular phase day. Cycles with a longer follicular phase resulted in higher clinical pregnancy rates with 45% higher odds of clinical pregnancy. Endometrial thickness increased by 0.1 millimeter with each additional day and was increased in the longer compared with the shorter follicular phase length group. And they found that in gonadotropin IUI cycles, follicular phase length impacts both the chances of clinical pregnancy rates and endometrial thickness independent of maternal age. Thereby, what this means is we should not look at shortening our cycles. We've been taught to start stimulation on day 3 instead of day 2 and thereby having a good follicular phase length. This is Dr. Mahesh Jariwala's protocol and it has worked fantastic for us. And thereby giving a stimulation for minimum 8 days, ideally 9 to 10 days, have a good trilaminar endometrium before giving a trigger and doing an IUI. So looking at a lot of times we have this question, antagonist dene ka ya nahi dene ka? So there was this paper from 2005 which mentioned that adding GnRH antagonist to the ovarian stimulation protocol for IUI significantly increased the pregnancy rate. While our own Dr. Abha Majumdar said and she found that addition of GnRH antagonist to gonadotropin IUI cycles results in no significant difference in the clinical pregnancy rate. So what to do? The Cochrane is the answer that gonadotropins alone are more effective than with addition of a GnRH agonist. No evidence of adding an antagonist to gonadotropins. No evidence of benefit of doubling the gonadotropin dose. Ideally start with 75, max 150. After 150 we should stop. For IUI I am mentioning, multiple pregnancy rates and ovarian hyperstimulation were increased, but that is with higher doses. With our regular doses of 75 and 150, we don't really see that much. And gonadotropins are the most effective drugs when IUI is combined with COH. And last but not the least, they are mentioning that it should be applied on a daily basis. India is the only country where we talk about giving on an alternate day or once in 3 days. There is no scientific basis for it. If you're using gonadotropins, it has to be on a daily basis. Is endometrial thickness important for IUI? We used to always think it is important for frozen embryo transfers. So there was this paper which evaluated the effect of endometrial thickness and endometrial blood flow on pregnancy cycles and on pregnancy in IUI cycles. They found that endometrial blood flow in color Doppler was found to be positively connected with the pregnancy outcome. So how does this affect us? If we have a woman whose endometrium is not thick enough with oral ovulogens, think of starting gonadotropins. With gonadotropins, it is not good enough. Think of increasing from 75 to 150. With that, it's not good enough. Add aspirin or sildenafil or arginine sachet. With these things, in majority of the patients, we always see a endometrial vascularity and thickness increases. And despite that, if it does not increase, just do a diagnostic hysteroscopy and see whether there are any adhesions or any Ashermans or any COX or any endometritis. There's another paper where they evaluated the association between endometrial thickness and pregnancy outcomes in gonadotropin stimulated IUI cycles. They found that the odds of clinical pregnancy and conception increased by 38 and 44% respectively, with each subsequent peak endometrium category up to 14 millimeters, after which it declined. So in our patients, if we are looking at a thinner endometrium, we want to increase it. I think we should not go beyond 14 millimeters. If it is beyond 14 millimeters, expect that there might be a slight decrease in the pregnancy rate in that woman. This paper evaluated the endometrial thickness after ovarian stimulation with gonadotropins, clomiphene citrate, and letrozole for unexplained infertility. They evaluated 2,500 cycles. The overall mean endometrial thickness on the day of HCG administration in cycles with a live birth was significantly greater than those without. They found that higher live birth was observed with increasing endometrial thickness, and appreciable live birth was seen at all endometrial thickness, even those less than 5 millimeters, suggesting that ovarian stimulated IUI cycles should not be cancelled for thin endometrium. So if you have sometimes an endometrium less than 5 millimeters, you might just do a IUI cycle, and especially when you've given her a gonadotropin stimulation and expect a slightly reduced results. We are often asked what trigger to be used in IUI. As I mentioned initially, we used to use HCG 5000. Now we've given up I 5000 completely and gone to HCG 10,000. Recombinant HCG can be given, but there have been lots of papers, especially a Cochrane paper, which showed there is no difference whatsoever between urinary HCG and a recombinant HCG. GnRH agonists can be used. Triptorelin was initially available, now it's not available due to shortage. Luprolide works exactly the same. If we are using triptorelin decapeptyl 0.1, use 1 ml of luprolide for a trigger, and it works exactly the same. We've been using this in donors and finding the same response. A dual trigger can be used, HCG 5000 with a GnRH agonist luprolide 1 ml. No trigger, and checking for the natural LH surge by LH kits and the serum LH levels. Though we really don't appreciate doing that for the simple reason that we cannot time our IUIs if we wait for the natural LH surge to happen. So at what size should we give the trigger? This paper evaluated the size of HCG trigger as the size of the follicle and HCG trigger in clomiphene citrate and IUI cycles. They found that the clinical pregnancy rates was 2.3 and 2.2 times higher with lead follicle sizes 21.1 to 22 millimeters and 22 millimeters respectively, compared to different category of 19 to 20 millimeters. So if we are doing a clomiphene cycle or a letrozole cycle, we would like to trigger them instead of 18 millimeters or 19 millimeters at 20 millimeters or 21 millimeters and have a better clinical pregnancy rate compared to what we expect at 18 to 20 millimeters. Effect of HCG triggered ovulation on pregnancy outcomes in IUI. This was an analysis of 5,600 cycles. They found that the clinical pregnancy rates and live birth rates were significantly higher for the HCG group than for the spontaneous LH group. However, this paper showed that there was no significant difference in clinical pregnancy rate when urinary LH and HCG trigger were compared as methods to time insemination in women with undergoing IUI. But for the sake of convenience, it is always better to give an HCG trigger and time an IUI rather than just wait for the natural LH surge to happen. This group, they evaluated the 3 trigger methods on the pregnancy outcome of IUI, the 3 methods being a HCG trigger, a GnRH agonist trigger, and a dual trigger. They found that the effects on the clinical pregnancy rates were same for all the 3 groups. IUI with trigger, Sometimes the patient can just come, the husband can come just for 1 day, and that is happens to be the day of the trigger. So this was a multicentric Dutch study where they did a intrauterine insemination simultaneously or 36 hours after HCG. This was a randomized controlled trial. They found that IUI at trigger has similar rates as IUI at regular time. Thereby, this gives an idea that if the husband cannot come after the trigger for giving a sample, you can just try doing the IUI along with the trigger and expect a pregnancy rate comparable to the regular IUI success rates. There is this study by Vadava et al. I'm adding this study here because they did an IUI audit at their hospital. It was a 4.5 years retrospective analysis. I think this is something, this is a good paper. We all should go through it, and we all should evaluate our centers as to what our success rates are. They found that their success rates were 15% in the first cycle, 14% in the second cycle, and 3.5% in the third cycle. And they found that the highest clinical pregnancy rates was noted when the endometrial thickness was between 9 to 11 millimeters. So this is the only Indian study that I could find. So this is probably can act as a benchmark for us as well. Next, we are asked as to, doctor, we want to do an IUI, but what all lab setup should we require? Do I need my own IVF lab? The answer is no. You can do with the Mackler's counting chamber, a phase contrast microscope, that's a simple microscope that the pathologist uses, a centrifuge machine, a laminar flow hood workstation, 5% CO2 incubator. If available, it's good. Otherwise, for IUI, not really a mandatory. Disposable, trained personnel. You can even train your staff nurse to do that, though embryologist is preferable. And this is how organized IUI setup would look like. Is it necessary to do semen washing for IUI? What is the premise of that? The idea is to totally eliminate the seminal plasma from the dead sperms, WBCs, RBCs, and prostaglandins. Chemical activation of the acrosome membrane. This increases the sperm motility. It minimizes the wastage as direct deposition in the uterine cavity at the time of follicular rupture. We can compare the pre-wash and the post-wash samples, and the sample is incubated at 37 degrees, thereby causing an activation of the acrosome and giving a better pregnancy rates before IUI. There are 3 methods for doing a semen washing. First is the simple conventional wash, where the semen sample is diluted with the medium and centrifuged. Pellet is taken, it is resuspended with a small amount of medium, incubated until the time of insemination. Second is a swim-up technique, which a lot of centers are doing. Migration, the idea is to have the migration of the motile sperms into the medium. The sperm and the medium is layered over that, it is centrifuged. The seminal plasma and other cells are removed. Culture media is added, it is incubated, and the motile sperms which move upwards is taken and loaded for IUI. Another more frequently used method, we use a density gradient for all, is a density gradient method, which is ideally to be used for oligospermia, teratospermia, or asthenospermia. In this, a conical tube, the gradients are layered, 1 to 2 ml of neat liquefied semen is layered, centrifuged for 15 minutes at 1200 RPM. Pellet is visualized at the bottom of the tube. Pellet is aspirated without disturbing the gradient and mixed with 1 ml of fresh sperm media. Centrifuged supernatant is discarded and swim up is done. Supernatant is aspirated, mixed with media, and incubated. This is the way. There are 2 nice density gradient methods, layers which are seen, lower percentage of 40%, which is there at the top, and 80% at the bottom. And the idea is that when the layering is done, the mixing should not happen. Sperm is deposited over it, centrifuged, motile sperms are collected down, that pellet is taken, and I have mentioned the steps that is to be done. So Cochrane even evaluated that for us, that doctor, I cannot afford to do a density gradient, or I don't have the method to do the density gradient. They say that there is uncertainty whether there is any difference in the clinical pregnancy rates, ongoing pregnancy rates, multiple pregnancy rates, or even miscarriage rates per couple between the 3 semen preparation techniques. So in their view, all 3 semen techniques are equally good or equally bad. You can do any which suits you. In our center, we do a double density gradient method. Now, this is a new chip on the block. This is called a microfluidic chip. Their semen are layered from the inlet. It passes the semen sample. It passes through the various channels which are there. Media is added. Motile sperms go into the other channels, and they are collected from the outlet. And this is how the chip looks like. It costs around 4,000 to 500 to 5,000 rupees, and this can also probably be evaluated for a single stop usage. Means, if you can't have an entire elaborate IUI setup, one might even think of just using a microfluidic chip for the purpose of IUI semen sample processing. So there was a paper which compared the microfluidic sperm sorting chip with the density gradient method for use in IUI cycles. They found that the microfluidic sperm sorting method significantly increased the ongoing pregnancy rates compared with the density gradient group in IUI cycles. So this is something that we need to keep in mind and offer it to our patients if previous regular IUIs or with any other methods have. Points to ponder. Should we do IUI semen sample processing in a regular pathology lab or in an andrology lab or a dedicated IUI lab? Definitely not a pathology lab, because there are a lot of chemicals going around the lab and a lot of VOCs are there which can affect the semen sample. Use of Mackler's chamber for analysis, though a positive thing for counting the semen, is not a mandatory. Incubation at 37 degrees for 30 to 40 minutes should be done for capacitation of the sperm before doing an IUI. IUI should ideally done within 1 hour of washing. A lot of times we see that husband goes to a center to get a semen sample processed, comes after 2 or 3 hours to get an IUI done. The patient is waiting in the clinical outpatient department, and after 3 or 4 hours, IUI is done. So this should preferably be avoided. IUI should be done by trained personnel with due precautions. Though it is a simple procedure, we need to give it its due importance. Now we've done the semen, we've done the ovarian stimulation, we've given the trigger, we've identified how to have our own lab or what methods to be done for IUI sample processing. So how should we push the sample? We all have been just pushing the sample blindly. It's like just giving a small vaginal wash. So there is this nice paper recently published where they have done something called a slow released insemination. I will talk about it in the next slide. They found that pregnancy rates following slow release insemination was 13% and 10% respectively for IUI. In women under 35 years of age, pregnancy rates with slow release insemination was 17% compared to 7%. These results support the hypothesis that pregnancy rate might be improved with slow release insemination compared to the standard bolus IUI that we all be doing, especially in women under the age of 35 years. So this is a nice EVIE slow released insemination pump which is strapped to the woman's thigh. A catheter, a disposable catheter, is inserted into the uterus and it is filled with 1 ml of saline. Semen sample is loaded and the woman can adjust the flow according to her own wishes with these two buttons. The pump ensures that the semen sample goes into the uterus in around 4 hours. How we can use this in our clinical practice? Rather than just doing a random push for an IUI, we can probably think of doing a slow IUI, maybe over 5 to 10 minutes, and evaluating our results, whether we get better results with a slow release compared with the bolus push that we all do. Then looking at single versus double IUI in stimulated cycles for subfertile couples, this is an old Cochrane paper. They stated that double IUI resulted in significant benefit over single IUI in treatment of subfertile couples with husband sperms. Optimal window of several hours seems to exist in which IUI can be performed, though the cost effectiveness of the second IUI needs to be evaluated. How much sample should be taken for inseminating during IUI? Should it be 0.2 ml, 0.3 ml, 0.4 ml, 0.5 ml? So this study, they evaluated almost 300 cycles where they gave 0.2 ml of donor sample versus 0.5 ml of donor sample. They found that there were lower miscarriage rates in the 0.5 ml group, and this is interesting. This could be related to the presence of uterine contractions similar to those generated during coitus, which may be implicated in the inception of early biochemical embryo endometrium communication. So when we are using an IUI sample, just ask your embryologist or your technician to ensure that the sample is 0.5 ml and not lesser, and hope for a better pregnancy rates. Now, does the time interval between semen collection, processing, and insemination affect the results? This paper was by Dr. Gautam Alabadia, and they found that IUI should be performed as soon as possible within 90 minutes of semen collection. There was another paper in Fertility Sterility 2017, which found that longer time interval between semen processing and IUI does not affect the pregnancy outcomes. So what they did IUI day after the collection. They collected today, and after 24 hours, they did the sample IUI. They collected the sample, did the processing, kept it in incubator, and did an IUI after 24 hours. And second was immediately the routine that we do, and they found that the pregnancy rates were similar in both the arms. Comparison of doing an IUI after 36 hours and 42 hours. This paper evaluated 165 patients. They found that clinical and the chemical pregnancies were significantly higher in the 42-hour group. So we can probably evaluate our own data that are we getting a better pregnancy rates doing an IUI after a slight delay. Normally we've been hearing of people doing IUI at 32 hours and 36 hours and 40 hours. We can probably do a double arm trial of our own where we can just give a trial as to 36 hours versus 42 hours and evaluate the results between the two. Now, this is another paper which evaluated the interval between insemination and ovulation. 1100 patients, they found, and this was for IUI with a donor sperm. They found that IUI donor is best performed within 19 hours of the insemination ovulation interval for higher probability of clinical pregnancy rate. Thereby, if the ovulation has occurred and you've been able to time the ovulation within 19 hours is the best time window for doing an IUI. IUI procedure, we all know, bladder is emptied, head low position or just a dorsal position. Cervix is visualized with a speculum. Mucus is wiped till external os is clearly seen. IUI catheter, many types are available. A soft or a rigid catheter is navigated just beyond the internal os, taking care not to touch the fundus and cause involuntary uterine movements and pain. 0.4 to 0.5 ml of process sample is injected slowly, taking care to avoid trauma and bleeding. And after that, patient is made to lie down for 15 minutes. Cochrane studied the results between soft and firm catheters, and they found that there was no significant difference between the two. However, the pain was lesser with the softer catheter. Another study, they evaluated clinical pregnancy rates with a firm catheter where they found it was 19% pregnancy rates. With the soft catheter, it was 5%. And surprisingly, when they used a tenaculum to hold and stabilize the cervix, they found the pregnancy rates as high as 31.7%. However, on analysis, there were no significant differences that were found in terms of live birth and miscarriage rates between all the three groups. There was another study which evaluated should IUI be done as a blind procedure or it should be done like a frozen, like an embryo transfer as with a ultrasound guidance. This study evaluated that the clinical pregnancy rates was same in both the arms and that the use of ultrasound is not required at the time of doing an IUI. This was an interesting study which compared the semen parameters in specimens collected early in the morning and late in the evening, and they found that from a male perspective, successful IUI may be easier to achieve using semen collected in the evening than in the morning. Someone actually bothered doing an IUI success rate during using the seasonal groups, and they found that the maximum success in IUI was in the spring group of 15.6%, and it was almost half in the summer group of 7.4%. So if in Mumbai we have just one season all the year round, but in case you are in from a place where you have 4 seasons, you can use this data and optimize and tweak your IUI success rates and evaluate your IVF success rates as well. Points to ponder. Full bladder in IUI can be used in cases of acutely anteverted uterus. A lot of times we are asked in the groups as to that I was having a problem dilating the os during IUI. So we've got recently good results by using a piroxicam tablet sublingually 1 hour before and giving an isoxaprine capsule 1 hour before, and the IUI could be performed very easily. And we've started doing the same at FET recently and found that navigating the internal loss even at FET is very easy and very cheap. If despite doing all this you cannot navigate the internal loss, you can do an intracervical insemination where your sample is deposited between the internal and the external loss. If that is also not possible, then ideally a hysteroscopy DNC and a dilatation with lineation of the cavity should be noted so as to facilitate IUI next time. Misoprostol should strictly be avoided because it causes contractions. The contractions are fundo-cervical and thereby it will just push the sample down, so it should not be used. IUI should be done after a trigger irrespective of the follicular collapse. Couples should be given a realistic success rates. We give a success rate of 12 to 15% if the patient is more than 35 years, less than that. 4-cycle ceiling strictly to be maintained in unexplained infertility patients. Only exception would be donor IUI where you can try for 6 to 8 times. Cochrane recently evaluated endometrial scratch, which we've been hearing a lot about for FET, whether it should be done for patients who are just having a normal coitus or for IUI. They found that the evidence is not sufficient to advise for routine use of scratching for IUI and normal sexual intercourse. IUI versus intracervical insemination, they found that though the pregnancy rates are always better in IUI and compared to ICI, and IUI may be associated with higher multiple pregnancy rates. Immobilization. Is it important to mobilize a woman after IUI immediately? So this was a randomized controlled trial where they found that immobilization for 15 minutes after IUI gave a better pregnancy rate, and they recommend immobilizing all women for 15 minutes after IUI. And they found that after first, second, third, and fourth cycles, they found that there was a significant difference in pregnancy rates in immobilized women versus mobilized women. So it's no harm, rather than just rushing the poor lady through, just let her lie down for 15 minutes, relax, and then ask her to just go her own way. This is another clinical scenario where we have patients who come with a unilateral tubal occlusion. There might be a coronal block, there might be a femoral block, one tube is open. So this study evaluated the effect of unilateral tubal block diagnosed by HSG on clinical pregnancy rates, and they found that the proximal unilateral tubal block diagnosed by HSG can expect similar pregnancy rates as normal bilaterally open tubes. However, when a woman is having a distal tubular blockage, you might expect a lower clinical pregnancy rates. Progesterone, should we be giving, should we not be giving? The study evaluated, they found in almost 4,000 cycles that progesterone support did not benefit patients undergoing ovulation induction with CC or CC plus gonadotropin. Another study evaluated oral dihydrogesterone versus vaginal micronized progesterone. They found that both had the similar pregnancy rates in terms of clinical pregnancy rates and the live birth rate in women undergoing IUI with stimulated by recombinant FSH. This is a special case that I came across, is IUI in HIV discordant couples, 69 fertile couples, wife negative, husband positive. They did a triple sperm washing and did a real-time PCR before doing an IUI. They found all the samples were negative for HIV. After delivery also, the babies were found to be negative for HIV. They did tested the babies twice, at birth and at 3 months of time. Thereby, for people who are doing HIV positive discordant couples, this can be a good method of reducing the transmission of HIV. And this is some another thought that came to my mind. Can this be a way forward in the current COVID pandemic, where COVID, again, it's a virus? When the husband has had a recent COVID, wife has been stimulated and but not been affected. Maybe doing a triple wash make the sample more safer. No data yet, just a thought that came to the mind. When should we call it a day? Kab tak IUI karna? When should we stop doing an IUI? So this study evaluated that is IUI a viable treatment option for women over 43 years of age. This said 43 years. If we see Manish Banker sir's paper, we Indian women are 6 years aging older than the Western counterparts. So we should look at 37-year-olds. So use of intrauterine inseminations in women more than 43 years and older is an ineffective treatment strategy. Even if gonadotropins are used, there was no chance that there was a better pregnancy rate. So maybe we can just call our patients at a ceiling of 36 to 38 years and not unnecessarily do IUI beyond 37, 38 years of age. Summarizing, Cochrane says in IUI for unexplained infertility, treatment with IUI with ovarian hyperstimulation probably results in a higher pregnancy rate compared with expected management alone without ovarian hyperstimulation in couples with a low predictive score of natural conception. IUI, a natural cycle, results in a better cumulative pregnancy rate compared to timed intercourse with ovarian hyperstimulation. What they mean by that is we've seen a lot of people who do a ovarian hyperstimulation give HMG and IUI is not done. So they recommend please do IUI. And treatment with IUI in a stimulated cycle may result in a higher cumulative live birth rate compared to treatment with IUI in a natural cycle. Lastly, factors affecting the IUI results: age, sperm quality, causes of infertility, response to ovulation induction, lab quality, IUI technique, and luteal phase support. Summarizing, this is the last slide, which shows that younger the patient, higher is the pregnancy rates with IUI. And there is no use going beyond 4 cycles, because after 4 cycles, there is a plateau in success rates. So if you have a patient with unexplained infertility, call it a day after 4 cycles and don't unnecessarily pull and waste patients' precious resources like her own eggs, especially if it's an elderly patient or a low AMH patient, and ask her to go for IVF. Thank you so very much for a patient hearing.
Good one. Can you stop the screen sharing and come back to normal? Venu sir, if you would just want to summarize everything.
I think Sachin, your talk was excellent.
Thank you, Venu.
If it was so exhaustive, but like it was filled with information. But I think the message at the end of it, what we would like to get is that the procedure and the messages out of your talk should be simplified. Is it not so? Like, it's not a procedure like IVF where you have to go into, over a lot of years, what I've realized is this, that, whatever you do, chances are less likely that you will go wrong with your IUI. It's not like IVF where, precision calls. But still, there are a few take-home messages. I think you gave your take-home messages very well. I would just like to ask you one thing, Sachin, that for all our audiences who are hearing this talk, suppose I were to ask you, Sachin Bhai, that what are the 3 things most important that you consider, that have changed or you feel that, are making your IUI results better? Then 1, 2, 3, in that order, what would you say matters the most for the audience, of course?
One is patient selection. The patient should have an adequate AMH, not a very elderly patient. Second, I have started doing IUIs with gonadotropin stimulation using a good brand HMG. That is very important. Giving a judicious trigger and a nice, after we have started the IVF lab, semen sample processing in the IVF lab has completely changed the results. Initially, we used to do it in a pathology lab, but that has changed over the past few years, and a good luteal phase support.
Yeah, Sachin, I asked this question in a very specific context, why the debate about the use of IUI came in the UK itself. That, there was a big debate. The NICE guidelines said that IUI is useless for unexplained infertility. The debate progressed, and then you put in a very good paper by Dr. Ghulam Bahadur. I think the
Yeah,
first paper that you put up
the
in your
first
talk.
paper, yes.
Yeah, and in that talk, for the sake of the audience, that he mentions two things there. One of which Sachin said, that he said about stimulations with gonadotropins. I think that makes a huge difference, he said. And the second he said was the use of consecutive samples in low quality semen. So your
Yeah,
comments on that? That
yeah. So this
until
is,
perineal yeah.
yeah.
In
So
that,
this is, yeah. So this is what we've been doing is on the day of trigger, we tell the couples to compulsorily have course on that day. I've had the privilege of speaking to Dr. Ghulam Bahadur at a conference, and this was almost 5-6 years back. And that was a time when he was talking about a split ejaculate or a second ejaculate within an hour. And they found that the DFI was significantly lower in the second sample. The motility was significantly better in the second sample. So that's what we've been doing is I've been telling my patient, if on Monday I am giving a trigger, on Wednesday I am doing an IUI, on Monday you guys be together, on Tuesday be together. If you feel that on Wednesday you can give the sample, if you feel that on Wednesday you might not be able to give the sample, then don't be together on Tuesday. 1 day gap is more than sufficient in getting the DFI down. Rajesh sir, your comments on that? Rajesh
yes,
bhai,
sir.
Yes,
I
yes,
think your
you're right.
comments,
your
then
comment,
you speak further, yeah.
your comments on
Yeah,
that?
it was an excellent talk, Sachin. Yeah. Oh, comments on which aspect?
On the decreasing the ejaculation interval.
Okay. So, especially when the sperm density is less, because very recent paper that has come up for IOI success rate, and it has been mentioned that if the sperm total motile sperm count is less than 9 million, the success rate is dramatically dropped down. So he suggested to increase the sperm density, you should have another ejaculation, and you can club together both the sample so that you can have a better sperm density. So that is what has been suggested, and we have been practicing that in case of severe oligospermia. So that is one thing about the split ejaculation. Second thing, it without any doubt, the ejaculation definitely decreases the DFI, fragmentation index, and that's the reason it's our routine practice to advise the patient. In my routine practice in IVF, the day I give trigger, I always tell the husband to ejaculate, to masturbate, and ejaculate the sperm, so that after 2 days, whenever he comes for, on the day of pickup, he gives the sample. I believe that sample is the best sample, having the lowest DFI. Although as per the study, it has been mentioned that if you want to decrease the DFI, then it should be not a one ejaculation or two ejaculation. At least it should be 5-6 ejaculation. So ideally, when any patient whom you are suspecting a high DFI, the moment you start a stimulation, you should ask the husband to ejaculate daily or on alternate day, so that by the time you reach at the to for the pickup or IUI, whatever case may be, the DFI is the least.
Right. So, no, sir, the reason I ask this is because we get this question asked by a lot of practitioners that should we be having a gap of 5 to 7 days before doing an IUI? Means won't the semen volume reduce or quantity reduce or the count reduce? So this is the specific reason why I asked you this question. Is that sperm, the testis is like a well, it keeps on producing sperms, it keeps on producing water. More you remove, more it's produced. And the freshest the sperms, the best quality sperms it is.
Yeah, and even though the count may decrease, but in terms of DFI, the sperm quality will be better. That's the little bit of a novice concept. That's why I think it deserved the attention and the discussion that we had.
Yeah, and motility, Venu.
Yes.
And motility, because we've actually done in our lab comparison of the first and the second sample, and our embryologist has persistently told us that the second sample has a better motility than the first sample.
True, I agree. Yeah.
I just like to add something here. As far as DFI is concerned, one should be very, very careful when you are including DFI as a part of your routine evaluation of male infertility in any partner. I think the biggest or the commonest problem with DFI evaluation is how is it being evaluated. Okay, it is not which laboratory you are sending it to. It is the actual technique which is being used to evaluate it. For example, somebody who is using a flow cytometry, which is a common old traditional technique of evaluating DFI, you will tend to miss out a lot of fragmented sperms because the channel in which the flow cytometry is done is not good enough. Let's put it that way. The ideal method to evaluate DFI is to prepare the sperm sample on a slide. Okay, under that agar-boss gel, it takes around 2.5 to 3 hours to prepare it, and then after it is done, you can use a CASA or you can use whatever you want to use, but it gives you a ratio in which the nucleus and the perinuclear halo is being present. And after doing that, actually it takes more than 200 sperms to note down on a slide, and it takes around 1 hour to evaluate that slide. And I think that should, if at all somebody wants to include DFI as one of the parameters, I think a lot of stress should be laid on how the DFI is being done. Because commonly, if you do it on flow cytometry, you have a huge potential of getting a falsely low report. Your report on flow cytometry is going to, let's say, tell you DFI is 10%, suppose, but actually the DFI may be 35%. And I think that is something which people must try and incorporate. If I'm wrong, somebody can correct me on this.
Yeah.
That's true. And see, the audience would have heard two things today in Sachin's talk. One is that he included a DFI as one of the criteria for doing an IUI. That's the first thing. And on another slide, he had microfluidics there. Sachin, I want to ask you that, patients, have you thinking of changing over your method of sperm preparation to microfluidics in your day-to-day practice?
Honestly, we did use microfluidic for 5 of our patients, and it really didn't make a big difference compared to the double density gradient that we are already using. I mentioned the microfluidic for a person who is probably new fertility, who has not started his own IUI lab and wants to do a semen sample processing. So probably the sperm sorter chip might act as a surrogate instead of a proper regular andrology lab and help out in the sperm preparation.
Yeah, so I think the message should go out properly that even though you mentioned microfluidics, it's not that tomorrow, you try and run around and try and find a microfluidic chip and try and do IUIs. No, I think Rajesh, would you agree with that particular thought? There'll be a lot of people who will be listening, and then, we have this natural, this thing, that, okay, some new magic has arrived and then we are into it. So,
Venu sir, I'd just like to add here that even if you are using the microfluidic chip, the microfluidic chip works best when you keep it inside a CO2 incubator. If you calibrate it inside a CO2 incubator. So that microfluidic chip it's actually refrigerated. It arrives and it has to be stored in a refrigerator. It needs to be calibrated inside a CO2 incubator. After you calibrate it inside a CO2 incubator for 6 hours, that's when you can use it for sperm sorting. And when you put the sperms inside the well, you need to recalibrate it. I mean, you need to put it back inside the incubator. So when somebody tries to replace the microfluidic chip with an andrology setup, it is absolutely wrong. It should be used as a complementary thing to your andrology setup. The andrology setup is the gold standard, in my opinion. And CO2 incubator, if you want to have any result from any microfluidic chip, CO2 incubator is the gold standard. You cannot use the microfluidic without the CO2 incubator. Korade sir, your views on this?
Yes, I agree. Can we quickly take up whatever the questions are sent in the chat so that all the viewers are satisfied?
Yes, sir.
So
sure.
Dr. Priyanka is asking, can we overlap letrozole with GnRH? Can we start GnRH from day 3 of letrozole?
He's meaning gonadotropins. Yeah.
Sachin. So GnRH instead of GNRH, I think he wants to say
gonadotropins. Gonadotropins, yes, yes. Yeah, so as I mentioned in my talk, that paper which compared letrozole plain with letrozole with gonadotropins, yes, definitely letrozole can be added with gonadotropins to reduce the usage of gonadotropins and make it more cost effective.
Dr. Subhangi is asking, is donor IUI safe during COVID times?
Absolutely, because the donor IUI sample processing is, we don't use a fresh sample. It is always from a sperm bank where the sample is collected long time back. Ideally, how the semen sample is processed in a sperm bank, I would just tell for the benefit of the audience. Today, the man comes and gives a sample. His HIV, HBsAg, HCV and other viral markers are taken. The sample is stored for 3 months. A repeat test is done. Once that test is negative, then the sample is given out for circulation. This is the way it is done. So if you are, a lot of practitioners have been using fresh sample. From where they get the fresh samples is all anybody's guesses. So from a qualified sperm bank, if you have a frozen sample with a profile of the patient, I think it's safe.
Yeah. Dr. Paridhi is asking, what about the severe luteal phase deficiency after GnRH agonist trigger in IUI cycle? Because in your paper, one of the paper, it is mentioned that whatever trigger you use, there is no much difference in the result. So she is apprehensive whether the agonist trigger would not cause a luteal phase deficiency.
So, sir, that is what we've been doing recently, as I mentioned, is initially we used to use a HCG 5000. Then we used to have a lot of unruptured follicles, so we went for HCG 10,000. Now, since the past 6 months, and this is not only from me, but from a lot of colleagues, I am hearing that HCG 10,000, after giving HCG 10,000 also, the follicular rupture is not happening. So we thought of giving a 1 ml leupride with 5,000 international units of HCG, and that is working fine. And giving a good luteal phase support, not estrogen, just progesterone, micronized progesterone vaginally 400 OD or BD, and we are getting pregnancies with that.
So Dr. Paridhi, luteal support? Yes, sir. 1 minute. Sachin, are you keeping the same luteal support even if your trigger is an agonist?
Same, because I'm giving a HCG 5000 along. Na? I'm not giving a plain GnRH agonist.
Okay.
I'm giving HCG 5000.
From your experience, does an agonist alone also work in these cycles?
Honestly, never used agonist alone because of this fear of the severe luteal phase deficiency. But probably Rajesh sir would be having more experience about that.
I think so. Rajesh sir, what do you think?
Yeah, I don't use dual trigger. I do not give concomitant agonist and SCG trigger in IUI cycle. I am fond of using agonist trigger in IUI cycle since last couple of months, I would say, especially from COVID era, during the COVID era. So what I do, I give agonist trigger because agonist trigger very rarely fails. That is what I have observed. Yes. The problem with the agonist trigger is luteal phase deficiency. Although evidences are there that does, as far as IUI is concerned, does not cause any problem. But still we are apprehensive because we know the physiology. So what I do, after agonist trigger, the LH activity is sufficient for 2 to 3 days, and which is sufficient progesterone is in circulation. So I am more worried about what can happen after 3 days. So I always add back a small dose of SCG after 3 days, and again give one small dose of SCG after 4 days of that. So that's how, and then in this cycle, even I can ovulate using progesterone. So many times I don't use progesterone. Just 2 injections of SCG, that takes care. And by the time implantation is over and embryo is implanted, it starts producing SCG, which can take care of luteal support by themselves. So this is how I do nowadays.
And no, sir, I agree with you. That's the point, Sachin, that I just wanted to, I think sir brought it out beautifully. The agonist trigger also works, provided you are able to modify your luteal support a little bit. Yeah.
Right.
Okay. Dr. Drasna is asking, at the time of trigger, do you advise looking for Doppler flow around the lead follicle?
Yeah, Dr. Darshana, there is this fantastic paper by Dr. Sonal Panchal and Dr. Nagori sir from Ahmedabad, where they have probably the largest series of Doppler studies in IUI patients, and they are able to actually time LH surges with Doppler flow studies. And taking a leaf from that paper, I've started doing, as I mentioned in my talk, that PSV more than 10 around the lead follicles and a good endometrial flow is when we would like to give a trigger. But the caveat is, if you don't have a Doppler flow, I don't really think, honestly, it makes a huge difference. I've spoken to radiologists, and they say, and radiologists who do follicular studies for others, they say that in their clinical practice, it does not really make a big difference. So it's whether you're a believer or a non-believer.
I'll just add one thing to this. When you are doing a Doppler study, one thing is very important. It is important what is your PRF setting. Okay, that is something called as pulsatile resistance flow. This is a setting which is available on every Doppler. Every machine which has a Doppler has this setting. Okay, remember, when you want to assess the follicles, this setting has to be got down to less than 0.6 or 0.6. You cannot do this as a standard assessment at 0.9 and 1.2, which are the pre-calibrated settings on the vaginal probe. 100% you cannot do it. If you do it on 0.9, you will think that the follicle is without flow. If you do it at 0.3, you will think that the follicle has a huge flow. 0.3 should be reserved to assess small parts or endometrium. Apart from this, if you are assessing follicles, it has to be 0.6 or below, maybe 0.5, 0.4, based on which machine you are using. And as Sachin Bhai pointed out, that the peak systolic velocity of the follicle, of the lead follicle surrounding the quadrant of the follicle, should be more than 10 centimeter per second. What is important to note in that is where you are looking at this, which part of the follicle, which wall of the follicle you are looking at. All right. When you keep the PRF at 0.6 or below, you will always have one flow which is going inside the septum, not through the stromal aspect of the ovarian follicle. When you look at PRF or when you look at the peak systolic velocity, it should be through the region of the septum. And I think that is something which is extremely important if somebody wants to do these studies.
Okay. So,
sorry, sir.
Yes, please,
Yeah,
doctor, please go ahead.
All the PRF and all this thing we are seeing follicular flow to, we want to time your triggers correctly, right? So Sachin, you had a very good paper. You in your talk, you had a paper by Dr. Abha Mujumdar on the use of antagonist. Okay, there now I'm not talking about the antagonist, but then the way you see that if you read that paper, the success rates shown in that were pretty high, like 23, 24%. So if just listening to madam, she said that when the follicle she meets the criteria size wise, what she does is she does an LH estimation, okay, or she takes an LH kit. If the LH kit is showing up 2 lines, then she will do an IUI after 24 hours. Otherwise, she will give an HCG and do after around 40 hours. I just want your comment regarding that one.
I have not read that paper, so I'm not aware.
Interesting to you? I thought it was an interesting.
Yeah, it definitely sounds interesting. Yeah, definitely.
Yeah.
So,
just for the...
yeah. So first of all, definitely there is a role of perifollicular vascularity. If you're not very, well versed with the measuring PSV, at least you should cultivate the habit of looking at the perifollicular flow. If the perifollicular flow covers more than 3/4 of the follicle, that's a good vascularity. And what happens if the vascularity of the follicle is good? That itself suggests a lot of oxygenation is there in the follicle. And there is a direct relation between oxygenation of the follicle and oocyte ploidy rate. So definitely to take some decision, if you take the help of vascularity, I think that should make your success more acceptable, and it's easy to manage. At the time of the trigger is better decided looking at the vascularity of the follicle. Not only the vascularity of the follicle, but I would suggest to look at the endometrial vascularity.
Yeah.
So if the endometrial vascularity is bad and the perifollicular flow is good, then you can look at the PSV, and if PSV is not 25 or something, if it is around 10, then it is better to postpone the trigger for a day and give a chance endometrium to still have a little more vascularity, and then give the trigger. So in my practice, definitely I take help of vascularity, and I am a believer that you should look at the vascularity. Then another thing, Dr. Venugopal was you asked about something.
No, I was asking about the role of LH
LH kit.
and measurement
LH.
for timing the IUI. Yeah.
Exactly. Now, Dr. Mahesh Jariwala and Dr. Prakash Patel has raised the hand, but we will not allow you to, allow you to speak just now because we want you to give a detailed input and summarize the talk. Because so that's the reason. You please note down whatever your input if you want to in your paper, and you give. Then we'll allow you to speak, and then totally you have to point out multiple things. So that's the reason why we are not unmuting you. I mean, that's the reason. Okay. So, Dr. Jay and Dr. Venu and Dr. Sachin, all of you, I think rather than IVF, IUI is the most controversial subject. Right from the beginning, which molecule to use for the stimulation, from that point of starting, if you look at the timing of the trigger, if you look at the timing of the IUI, if you look at single versus double IUI, if you look at the antagonist, if you look at the role of contraction, uterine contraction in success of the IUI, role of misoprostol in IUI, role of holding the cervix in IUI, there are a lot of triggers, selecting the trigger. Everything is full of controversy. Everything. There are controversial conclusions in all of them. Now, you in your slide, you suggested that you put anovulation is the first indication of the IUI. If you look at our reproductive endocrinology book, it is clearly mentioned. Anovulation, you treat anovulation. Why you want to do IUI?
Right.
Similarly, but that is not 100% correct. Simon, I have seen the paper where it is mentioned that the best result you get in anovulation. IUI results are best in anovulation when the patient is having anovulation. So I don't deny, but at least in anovulation, I consider at last, if I can make the cycle ovulatory, I will not jump to IUI to enhance the success rate. That's what I believe. So again, coming back to a lot of controversies, now a lot of people, almost more than 156, 200 people have joined, and they are eagerly waiting to, get the take-home message. What exactly should be done? So, nutshell, if I ask you, I have understood that your preference is gonadotropin. Am I right?
Right, sir.
Rather than oral drug, you prefer gonadotropin. So
Yes,
that's
sir.
the message is well taken. You are happy with the gonadotropin with IUI. Now coming to a second thing. What is a trigger criteria in your center when you are planning for IUI?
Yeah, so when I am planning for IUI, I see that there should be the follicle size should be minimum 17 to 18 millimeters. The endometrium should be more than 7 to 8 millimeters. The perifollicular flow is what I see. The PSV ideally should be more than 10. Endometrial vascularity should be good. And that is when I would give the trigger and do the IUI.
Are you believer of single IUI or double IUI?
As I mentioned, sir, I majority of the times do a single IUI. The only time when I would be doing a double IUI is when I'm using a donor sperms or when it is a very severe oligoasthenospermia where putting more samples would give a better results. And another place where I have now started doing a double IUI is when we are having multiple follicles. I like to do a slight amount of ovarian hyperstimulation, get to no more than two, around 3 to 4 follicles. So in these times, I prefer doing an IUI after 36 hours and 24 hours after that.
Now, when you are doing IUI after 36 hours of trigger, and you are not using LH measurement you are not measuring the.
Not measuring LH. Is my internet bad or sir is frozen? Jay?
No, I think sir's internet has gone little bad. So I'll come to that question. As far as that LH is concerned, do you recommend measuring serum LH on the day prior to trigger for all
Not for
patients
IUI.
in IUI?
Not for IUI. That would be an overkill.
Yeah,
Not really needed.
It would be an overkill, but then again, I was telling you, Sachin, about just using a simple LH kit. In case you feel it's an overkill, then you just use an LH kit, and then if the LH kit shows 2 lines, then that means you are near. So you do at 24 hours. Otherwise, you do at your 36 to 38 hours. That was the thought. That's why I thought.
Right.
I also thought it was an overkill, and also for that you need to have a baseline LH first to see
Right.
that if there's a 3 multiplied by effect on the day just prior to the trigger. That's the only way you can find out. So that would be an overkill. But I think there is definitely a role. Rajesh sir, we are back. Yeah.
Cytrolics, see, now I put in another way. What are the advantages and disadvantages of Cytrolics? So first, let me say a couple of words about disadvantage. The commonest disadvantage of Cytrolics is cost. It adds the cost. Second disadvantage, which is not very well proved, the side effect of antagonist on endometrium, which is not proven. Very single or 2 papers are there saying the antagonist has got an adverse effect on the endometrium. So, largely speaking, using antagonist should not be objectionable. Now, what are the advantages of using antagonist? Is you are buying the time. Suppose endometrial flow is not good, suppose perifollicular vascularity is not good because of the insufficient estrogen, and you want a follicle to grow so that more estrogen is secreted, so that the better endometrium is formed, better vascularity and everything perfectly fits into your criteria, then you give trigger. So to manipulate the cycle favorably, the antagonist definitely helps. The only disadvantage, it adds a cost. There is no other disadvantage. In fact, in a very well-known study, they compared without using antagonist, the success rate, cumulative success rate was approximately 34% or something. And when they use antagonist, it jumped to 57% cumulative success rate. So I'm not against using.
Can I just add one point here, Rajesh sir? So in my talk, I think I mentioned that one place that I've been using antagonist recently is when, as I told you, prefer having a slightly over stimulation. Now, this is not for the audience who don't have an experience of ovarian stimulation for IVF. For a person who's just doing IUI, it should be 1 to 2 follicles max. Now, I like to have 3 to upper cutoff limit would be 4. Above 4, I like to either convert to IVF or cancel the cycle. So what I have started doing recently is use 0.125, half dose of Cytrolics for 2 or 3 days. And I've got good results in pregnancies. Now, the thing is that my numbers are not large like Jay does to publish data. But maybe I think combined we can just come together, pool our data and publish it.
Yeah, that's true. I totally agree with you. So a lot of questions are there. So my other co-moderator, please decide which question to be taken.
Let us finish the questions from the audience first.
I think that is our priority. That should be our priority.
I think.
So should I change role? Should I ask that?
I'm looking at most of the questions and quite a lot of questions. So I'm requesting people who are asking questions on similar lines to please post the questions on the Telegram group. Let Sachin bhai find some time by the night, and we have a masterclass Telegram group. You can post your questions there and let him answer, because most of the questions are repetitive. All the things which are different, let's address these different questions. So for example, I found a question. I mean, there are many questions here, 27 questions, which I've just noted down totally. So I'll just tell you, somebody has been continuously asking about the LH kit and worried about the sensitivity of LH kit. So I'll just tell you something which I do. And I really don't worry about the cost, because I'm somebody who charges very nicely for IUIs. My IUI charges are more than IVF charges at most centers. Okay. So I routinely do serum estradiol and serum LH for all the patients on the day prior of the trigger. When I'm thinking of giving the trigger, I am doing serum LH and serum estradiol. And I'm very happy to give HCG trigger if LH value is less than 9. I do not give the HCG trigger to the patient when LH value is more than 9. Similarly, if the serum estradiol level, I normally like to do 2 or 3 follicle stimulation for almost every patient. I don't like to go in for monofollicular. And if serum estradiol is more than 350, we are very happy. Okay, we don't wait for endometrium to advance on all these things, because that is a very good serum estradiol level to achieve whatever the endometrium correlations we might achieve. But of course, people can have different protocols to that. I want to ask one question specifically which has come up, and one question to Dr. Koradia on this, and I think Dr. Koradia and Dr. Venu can take this question, both of them simultaneously. So in all these things, all the drugs which we have been discussed, we have completely eliminated clomiphene citrate. Okay, and of course, there are papers stating that clomiphene citrate is definitely on its way out as far as IUI is concerned. Korade sir, I would like you to address the situation of using incremental letrozole protocol in IUI.
Incremental step-up protocol, incremental.
Incremental letrozole.
So you mean to say you are given letrozole 2.5 milligram for 5 days and there is no response. You called the patient after 7 days and then there is no response. So you would like to increase, make it double, 2.5, 1 BD. Again, you see after 5 days and then there is no response, you make it 3, 2.5, 3, 1 TDS. So step protocol. You are talking about step protocol?
No, I'm talking of a protocol where, let's assume on day 3, somebody has been given 2.5 mg BD. Day 4, it is again 2.5 mg BD. Day 5 and day 6 is 7.5. So 2.5 becomes 102, 102. And then on the day 8, it becomes close to 10 mg.
No, I don't think it is a physiological reason. Ultimately, what is the role of letrozole? How it acts?
Yeah.
It acts. Look at the basic. It stops the conversion, aromatase inhibitor, so a lot of androgenization of the follicle, and because of the androgenization of the follicle, it increases the sensitivity of those follicle for native FSH. Now, if you go through the minutest the paper which describes the what you call pharmacokinetics and other things, for to have the adequate androgenizing effect of increasing the follicle sensitivity, just 2.5 milligram of the letrozole is sufficient. So anything more than that, whatever you give, it really does not add any positive effect, provided you are relying on native FSH. Suppose if you were to supplement with the exogenous FSH, then things would be different. But whenever you are relying on native FSH, 2.5 milligram is just sufficient. I don't think there is any point in incremental dose of letrozole to be used.
Too much of step is too boring, Jay. Come on, you take the lift. Gonadotropins are there.
No, here I would just like to add a protocol that I've been using a lot of times and I've been talking about on the groups is the extended letrozole protocol. It works out very cheap. I start from day 3 of the cycle, 2.5 milligram OD. Only if in the previous cycle the woman has not responded to 2.5 milligram, I go on to 5 milligram OD. It's not BD, but OD. And that continues till either the lead follicle is more than 16 and gathered its own momentum, or till the day of trigger. If I have a feeling that after stopping the letrozole, the follicle might shrink. In that case, I continue for a couple of days more and till the trigger, and we've got good pregnancy rates with the extended letrozole protocol. If you go to the original extended letrozole protocol, it mentions about giving it for only 10 days. But if you have a patient who's got a really huge bulky PCO, in 10 days, that amount of FSH sensitization is not going to occur.
Yeah, I agree.
Now, very interesting question I'm asking to all of you. See, we are not Jay Mehta. We are not doing a lot of hormonal analysis in IUI cycle. So suppose if you think that double IUI you want to do. See, first of all, let us understand. Is there any disadvantage of double IUI?
No.
Comment please, all of you. Apart from the cost, is there any disadvantage of double IUI? Dr. Venu? No
No, I don't
disadvantage.
see any disadvantage. Yeah.
Okay. Now, Dr. Sachin has mentioned one paper where after washing the sperm, for some reason, suppose husband is not available for second IUI, the first day washed sample can be used on second day. Am I right?
Right,
And there
sir.
is no difference in the success rate.
No difference.
So now suppose looking at this conclusion of this paper, looking at there is no disadvantage of double IUI. If you want to implement a preference towards double IUI, what is the way forward? What is the ideal time gap between two IUI? Because on one side, we have paper which says that if you do IUI just after the trigger, success rate is same. We have paper which says IUI, if you do 12 hours after the IUI, single IUI, success rate is same. We have paper IUI, if you do between 32 to 40 hours, the success rate is good. We have paper IUI to be done after 42 hours. So really, we do not know what is ideal time of doing IUI. That means,
Right, sir.
okay, that's sometimes I feel what is ideal time. Really, we do not know after washing the sperm, the capacitated sperm survive in the endometrial cavity. How long? Fertilizing, retaining the fertilizing capacity, how long? Whether sometime I feel that while doing IUI, some of the sample should be purposefully injected, kept in the cervix, so that those sperms enter into a cervical crypts and keep releasing after some time, similar to like slow IUI, which one paper you mentioned. I think that is one modification I would suggest. Some portion should be injected in the cervix so that in the crypt the sperm remains for a couple of hours and gradually release and climbs in the endometrial cavity. So, what is the ideal gap if you want to do a double IUI? See, without my only worry in giving the trigger, I do not know what is the status of the LH. Whether follicle is going to rupture next day or not. Whether if I do not do IUI next day, am I going to miss the bus or not? So I always give a trigger and I always call the patient next day because I'm not aware about LH. So I always call the patient next day. I always do IUI next day and keep the portion of washed sperm at room temperature. Again, I'm calling the, suppose on that day patient, the follicle has ruptured, then I will not do second IUI. But if the follicle is not ruptured, I will call the patient again second day and whatever washed semen was kept at the room temperature, I use that sperm for the second insemination. And I have seen it that there is no difference in the motility. Believe me, all the time I check the motility. The post-wash sperm motility at 0 hours and after 24 hours, there is no difference. The motility
The sperm survival test you're talking about. The sperm survival test.
Yes. So this is, I think, a practical way without spending too much and increasing the cost extra to cover up the timing of the ovulation.
That's a good protocol, sir.
Yeah.
There's one question here about the length of the follicular phase. Do you consider the number of days to be important? I think you can answer that. Like, day 9, day 8, how many before giving trigger?
As I mentioned in the talk, I like to mimic the natural cycle of the woman. So minimum 9 to 10 days before giving the trigger.
And next question is dual trigger. How much time difference between the two drugs?
I give the same at the same time. But as Rajesh sir said, that is also sounding like a good protocol to give an agonist first. 48 hours, give the HCG 5000. After 3 days, HCG 5000. And again, after on 7th day, HCG 5000. Yeah. Right, sir?
So, no, sorry to correct you. I do not want to increase the cost that much because then full 5000 dose is not required. So what I do, I give half injection of SCG 5000. I keep that syringe labeled in that patient name for 3 days and again give half remaining dose of SCG. And this way, SCG can be used SCG is stable for next 3 to 4 days, it can be used like that. That is what has been mentioned in the paper from Egypt, Abulgar paper, it has been mentioned. So definitely this way SCG can be used and you can cut on the cost.
Sir, I will give a good Indian jugaad for that. Jugaad. We now have a liquid stable HCG available.
Yes.
So that is in a liquid form only. आधा आज use करो, आधा 3 दिन के बाद use करो. And the cost to us is the same whether you are having the lyophilized HCG or the liquid stable HCG.
Absolutely true. Absolutely true.
Yeah.
So another question quickly. Yes, Dr. Venu.
There is one question regarding your red flag follicle numbers for risk of ovarian hyperstimulation. 4. Yeah. 4. So the question is that if there are 5, then what do you do? Cancel.
Or if I am doing, if you are comfortable with managing OHSs, and trust me, I have never seen a single patient of OHSs. You can just give empirically cabergoline and just see what it is. But I would rather not go beyond 4. And as I mentioned, the stimulation is such that we will not get more than 3 or 4 in majority of the patients.
Sachin, when you cancel a stimulated cycle, a patient is hyperstimulated, you cancel, you don't give HCG, but then what happens after that? What are you doing?
I was expecting this question. So what I do is I give 2 doses of Cytrolics 0.25 साथ में. Together, that is 0.5, and trust me, in 24 hours, everything shrinks.
Okay. So another question: Lufastone or Sustain better for LPS? Rohita, same.
Both same in my opinion. Sir, your opinion?
Okay.
You are more knowledgeable.
No.
I like Lufastone.
Lufastone. Yeah. Lufastone, because it has a extra age of immunomodulation. All progesterone, they are basically immunomodulator, but then Lufastone has got age over other progesterone. So it's always a preference.
Rajesh sir, even adding HCG in luteal support after agonist trigger, it's 1500 units, correct? This question is how much HCG to add on day 3 post IUI, that question.
Sir mentioned 2500.
See, ideal, whenever you are using SCG as a rescue or dual trigger, the dose is 30 unit per kg of the body weight. So that comes to 1200, 1500, 1600, somewhere here. But why to break the head? Take 5000, make it half, give. Give it a more.
Good jugaad.
We all 3 are Guju. So
Okay.
Venu sir, look at it this way. When you give HCG 5000, you charge 5000 rupees. When you give HCG 10,000, you charge 10,000 rupees. Okay.
Okay. Any more questions, Jay, on the chat?
Yeah. There is one question. From what I see, this is the question. Final washed sperm should be placed in IVF medium or in MOP, which is better to be used in case of a double IUI cycle. So according to me, if I were to answer this question, then I think MOPS or HIPIS is very good. You may or may not choose the IVF medium or fertilization medium or any other medium in order to do this thing. It really doesn't matter. The ingredients which are present inside the IVF medium or a single step or whatever you are trying to use, they have got no benefit over the sperm. So, and especially for the exposure time. So if you are keeping it for 2 hours, 1 hour, it's really not going to matter. So I think equilibrated HIPIS or equilibrated MOPS is equivalently effective in my opinion.
No, I think, I would, if somebody is doing a batch IVF, they have to open the IVF medium during the time of the batch, while IUI keeps on happening. So I really would not recommend an IVF medium for an IUI. You can just use a simple HIPIS or a MOPS rather than wasting money. It would be an overkill.
Sachin, this question of time between your antagonist dose and trigger dose is a favorite question. So,
can I skip that? Rajesh sir would be a better person to answer that.
No.
More scientific.
So SCG if you are if you are planning for SCG trigger, you can give antagonist whenever you want, because both has nothing to do. The mode of action is different. The SCG directly acts on the ovary, and antagonist is blocking the pituitary. So there is no problem. SCG can be given anytime after antagonist.
Yeah, the difference comes when you're trying to use a agonist this trigger, no sir?
Yeah. Agonist trigger if we are using, then at least there should be a gap of 8 hours. 8 hours. 8 hours. Maximum minimum gap is 8 hours.
Yeah. Keeping in mind the half-life of the Sachin, when the follicle grows faster and the endometrium has time to catch up, then what's your strategy?
See, again, the follicular will grow faster if your stimulation is stronger. This is very commonly seen where, people will start with HMG 150 or 225 or recombinant FSH 150. So if it's already happened, there are two options. One is try giving antagonist and reducing the dosage and hope that the endometrium will catch up. Or second is, if that is not a probability, then cancel the cycle and next time reduce the dosage.
Yeah, and clomiphene cycles, I think if you're using clomiphene, you can wait, no? 22 minutes.
No clomiphene, Venu. Now, I think majority...
Still many people would be using that. But clomiphene, you can remember that you can wait for a bit more longer. You don't have to worry because many times the endometrium catches up later. Yeah. Sir?
Dr. Surjit Kaur is asking, should we give estrogen for luteal support after agonist trigger? No, not needed.
Not needed.
Then
brand name and all.
Please elaborate about gonadotropin and IUI and doses. So, what is a maximum dose which you would like to use, if keeping in mind evidence of the multiple pregnancy? Suppose if you do not want a multifetal pregnancy, what's a dose which you will use in IUI?
Right. So, good question. I was actually expecting this question. If it is a PCO woman, then I would, most important thing is to use a gonadotropin from a good brand, which will give you a consistency in the batch to batch with a proper cold chain maintenance at the level of the distributor, and thereby giving you a better, more reliable ovarian stimulation. So if it is a PCO woman, we normally would like to start off with 37.5 or maximum of 75 international units of recombinant FSH, and under no way exceed 75. If it is HMG, if it's a thin woman, maybe a HMG XP 75. Majority of the patients, I would use a HMG XP 150 and in no way exceed a dose of HMG 150. If you want in no way a multifetal pregnancy, then we should be targeting a monofollicular genesis, for which letrozole is the best.
So if you go by evidence, the maximum dose suggested for the minimizing the multifetal pregnancy is 112.5 unit. So once you are trying to cross 112.5 unit, you can expect multiple follicle growing. This is in general. This varies from subject to subject depending on BMI and the etiology, PCOS, non-PCOS, etc. So Dr. Ashish Vakil, he is a very dear friend of all of us, and he's doing very fantastic work in a small town in Gujarat. So he has updated one, he has said that after wash, 20 minutes incubation of the sample increases the success rate.
Yes.
Absolutely fine. Because the reason of this is, see, a lot of people will keep talking about immediate IUI once the sample is ready. Like Dr. Ashish said, I also never do IUI immediately. I keep in the incubation for at least 20 minutes. So for a reason, because it gives time for sperm to decompensate, DNA decondensation, I would say. Sperm DNA decondensation time is given once you keep the sample after washing. But that frame, the time frame is between 20 maximum 80 minutes. So it should be done between 20 to 80 minutes. If you do after 80 minutes, then it is hazardous. If you do before 20 minutes, then it is hazardous. But ideal time will be 20 to 80 minutes. So it should be done because better sperm DNA decondensation occurs because of that. That is a research paper.
120 minutes. Okay, we are at 120 minutes for the session.
So we can call it a day, Jay?
Maybe 5 minutes more.
Sachin, should we be giving a message to the audience also that it pays to occasionally visit the lab where the semen preparation is being done and then to have a look at the prepared samples also?
Always.
Very vital, we are discussing about success for IUI. It's not about simulation and clinical protocols alone. Those things.
Lab is equally important.
Yeah, that's very important.
I think I would add one very small point here. Okay, and I think Sachin Bhai knows about it. So see, we have a CASA machine at our setup. Okay, for doing all this DNA fragmentation and all these things. And in CASA, there is a beautiful system of CASA IUI. So if anybody has a machine for computer-assisted semen analysis, it gives you a protocol for IUI also. It absolutely does not add 0.0001% to the success rate. It does not add. But one good thing which it does is, it gives you beautiful videos of how was the pre-wash count and how is the post-wash count.
And Jay, it gives you a good chance to display your wares also. I saw it on your site. Okay.
Yeah. It's marketing. I'm telling you, it does not. In fact, when I bought it, I told you it is for marketing. But it really helps in showing the patient that at least the sperm preparation was done correctly.
Correct.
Okay, because it gives those computerized counts to it.
Correct. And the point we made is we should have a look at what happens. Semen preparation occasionally, we are having people helping us out, and then that's very important also.
Yeah.
So
very important.
So at the bottom line, if we use all our evidence, experience, wisdom, everything, and if you want to summarize, I would like to say that whether you use oral drug or gonadotropin, no much difference. Whether endometrium is 6 millimeter, 6.5, 7 millimeter, there is no much difference. Whether you use agonist trigger, SCG trigger, dual trigger, no much difference. Whether you do IUI immediately after trigger, 12 hours after trigger, 36 hours, 42 hours, no much difference. If the total motile sperm concentration is 10 million, 9 million, 7 million, 6 million, at least 1 million sperm should be present in your inseminate volume. Inseminate volume 1 million should be there. Then the success rate is not much compromised. Even the endometrium is 4 millimeter, then also descent 5%, 6% success rate is there. So don't be panicky, don't be too much precise for timing and trigger and gonadotropin and whatnot. Try to select the good case which is ideally suited for IUI. Do in the best possible way. Whatever we do, the success rate is not going to be more than 12%, 13%, 14%. Once in a while, you may get 20%. So it is just a little better modality in selected case where it works better than time intercourse. Nothing more than that. IUI is not should not be considered as something, and it should not be reflected in the patient's mind that okay, this is very fantastic and any different treatment and it is going to give a very good success rate. No, success rate is limited. That is what all I would like to say.
Exactly. Like I started,
good summary.
Much wrong. You can't go much wrong in IUI. So it's a win-win situation everywhere.
Yeah.
No, but then see, even if you can't go much wrong in IUI, what we should do is IUI can act as a stepping stone towards IVF.
Oh,
if your protocols are good in IUI, you will find it easier to do IVF when you eventually migrate to IVF. And at the end of the day, see, the patient is trusting you, her body, her money, her everything, so you should at least make an effort to try your level best and give the best possible success rate. And we have got pregnancies with IUI. We've got a lot of people who say that they've got pregnancies in IUI with patients who have got failed IVF.
Right. And coming to your Ghulam Bahadur paper again, if you see Sachin, you put it was so nice. It shows the success rates of a cumulative IUI and IVF. Each other. That's the point behind your wonderful talk today. So for which you should be congratulated very elaborately.
Thank you so much. Somebody had raised the hand. I think Dr. Jariwala or Dr. Prakash Patel, they had raised the hand.
Yes. But now they were disappeared.
Oh, okay. All right.
No, I think further questions from anyone, please post them on the masterclass group or on any of the groups, and Dr. Sachin will answer those questions. We will not be entertaining any questions from anyone at the current moment. I think it's been around 130-minute session, and I hope each and everyone has had some take-home points. This session is going to be recorded and it is going to be available for download only on the group. It is not going to be available on personal message, on WhatsApp message. Nowhere it is going to be available. I think what is important that members understand, and I just wanted to give this clarity to people, that when a person is preparing for an IUI session, and when there are two moderators across the country who are coming from different parts and different states of our country and are trying to give some understanding of this particular topic, I believe people who are genuinely interested must take out some time from their extremely busy schedule and attend these sessions rather than only asking for recording. So as a part of the protocol, henceforth onward, anybody who is asking for recording will have to pay some lump sum amount straight into the bank account of the person who is taking the session. Okay, not in my bank account, not in moderator's bank account, in the account of the person who has taken that session. Because typically when people just ask for recordings, I somehow don't like it, and I'm not a very politically nice guy, nor do I have any ambitions to be correct about these things.
I think all four of us.
Yeah, I just hate it. Okay, I don't like it. You can attend the session. These sessions are kept at 8 o'clock on a Saturday evening, irrespective of the type of practice which you must be having. And I believe you must be having a practice where you can't even go home to sleep. Okay, but since you are awake, you must take out time, attend these sessions, and stop your OPD for 1 hour. Okay, so that you respect the guy who has prepared for almost 4 days and 5 days to give out sessions with so much clarity. Okay, and I think that should be a very important take-home message apart from IUI.
On that note, Jay, can I do a session every day if the money is coming to my bank account?
We don't mind.
But on the whole, jokes apart, it was a fantastic session. Had a great time. The audience was amazing. The moderators were amazing. And look forward to doing such sessions again. Jay, Rajeshwar sir, we are planning one session on triggers. My associated Bhavna has helped in making the wonderful presentation on triggers. And after